Hello, everyone. On behalf of the Spina Bifida Association staff, welcome to the Spina Bifida Association's Community Information Session, Growing Up After Myelomeningocele Repair, What Moms 3 Teaches Us About Young Adult Outcomes. During this session, the CHOP team, Children's Healthcare of Philadelphia, will explain the earlier mom studies. We have people that's not part of the CHOP team, sorry, share what they've learned so far, talk about the new Moms 3 study and why it matters, explain how families can take part if they choose. Our speakers for this session include Dr. Katie Schmidt, who's worked at Children's Hospital of Philadelphia since 2006. Now Katie is the Fetal Spina Bifida Program Manager and coordinates care for patients and families affected by spina bifida. Katie works to support patients and families and is involved in programmatic development and research studies related to this patient population. Katie is one of the co-investigators for the research study Follow-Up in the Teen and Young Adult Years to the Management of Myelomeningocele Study, MOMS 3, which is currently enrolling at CHOP, Children's Healthcare of Philadelphia. Katie is passionate about improving the lives of those affected by spina bifida. Dr. Amy Houtrow is professor and endowed chair in the Department of Physical Medicine and Rehabilitation and Pediatrics at the University of Pittsburgh School of Medicine. Dr. Houtrow's career focuses on optimizing the health, function, well-being, and belonging of children with disabilities. Her research spans clinical outcomes to health services research for children with disabilities, with an emphasis on access to care and health equity. She has also been heavily involved in the MOMS 3 study, contributing to its overall design, assessment of data quality, and analysis. Amber Loff currently serves as a clinical research coordinator for the MOMS 3 study at CHOP, where she supports study operations, recruitment, data management, and manuscript preparation. She is passionate about maternal and child health and implementation science, interested in understanding the best approaches for turning research findings into routine practice and actionable solutions that lead to better patient outcomes. My name is Judy Thibodeau, a member of SBA staff, and I and my colleague, Juanita Panlander, will be with you for tonight's presentation. Welcome, Katie, Amy, and Amber.
Well, thank you very much. And I can say on the behalf of us, we are very excited to share information about MOMS 3. And none of that would be possible without our principal investigator, Scott Adzik, who has been involved in the fetal repair of spina bifida for decades. He is the surgeon in chief at CHOP, and he's our principal investigator. He has been involved in this work since its inception, and that goes back over 2 decades. We're going to take some time and learn about the work that came before MOMS 3. So the original MOMS trial, which the myelomeningocele, the study of fetal repair in myelomeningocele. I also want to let you know that we have an incredible team that includes, as you know, Katie and Amber, but also experts in multiple disciplines. For physical therapy, we have a psychology consultant who is world-renowned spina bifida researcher, and many co-investigators and people who support the program, and it would not be possible for all of their hard work. We're incredibly lucky to have funding from the foundation at CHOP that allows us to gather all of these amazing experts from CHOP as our part of our study team. So spanning all the sorts of disciplines that might be involved in the care of young people with spina bifida, from those who get involved at the very beginning, such as doing the neurosurgery to close the back after birth, to our urology colleagues, psychology, neuropsychology, maternal fetal medicine, orthopedics, and of course, every kid with spina bifida gets a ton of x-rays and imaging done. So we have radiology support as well. In addition, there is a whole team that helps us from a data management perspective and statistical support, which makes all of this work possible. We are doing quite a lot that you will hear about in terms of what we're looking at for this study, but I'm going to take us backwards a little bit to go over the management of myelomeningocele study, which is the MOMS original trial. So way back when, this study started enrolling maternal fetal dyads back in 2003 for a randomized controlled trial comparing both the safety and the efficacy of prenatal or fetal closure of myelomeningocele versus what's typical, the standard after a baby is born with spina bifida closure. So this was a major, big study that was funded very luckily by the National Institutes of Health, and they were actively involved. There were 3 clinical sites: the Children's Hospital of Philadelphia, where we're holding the current study, UCSF, University of California, San Francisco, and Vanderbilt University. In addition, we were very lucky to have the Data Coordinating Center at George Washington University, which also did this monitoring and safety of the study, which was essential to make sure all of the work was well and appropriately done. We were intending to be able, in this original study, to enroll about 100 maternal and fetal dyads that would be randomized. So they would flip of a coin go into the prenatal, and 100 that would flip of a coin go in the postnatal. So 200 different mother fetal dyads randomized 50-50, flip of a coin, to either fetal repair or standard postnatal repair. The amazing thing that happened is it was actually stopped early because the findings were so substantial. What Moms was looking for was seeing if there was a reduction of needing to have a shunt, and also other outcomes such as physical functioning and development, and also brain findings as well. This study was something that I only learned about because I was a youngin' back in the day and wasn't a practicing physician. I learned about this study when we were getting ready to write Moms 2, the follow-up study, because I was on faculty at UCSF in San Francisco and got to work closely with the team there that included the fetal surgeons and the neurosurgeons who were involved in that study. Been very lucky and honored to be so. So this major findings, they were published in the New England Journal of Medicine in 2011. And as was anticipated or hypothesized in the study, there was a decreased need for shunting at 1 year of age, which was the main outcome. Many children with spina bifida have hindbrain herniation. You might also hear this talked about as Chiari malformation, where the kind of the back part of the brain is sucked down into the spinal canal area. That was reduced for the babies that were in the fetal repair group. And in addition, when they were 30 months old, so not quite 3 years old, they had improved motor outcomes. Some things that you should know: everyone was worried that fetal repair would lead to early birth. And in fact, the gestational age, instead of being typical 37 to 40 weeks gestation when you're born, was 34.1 weeks. And about 13% of the kids who were in the prenatal or fetal closure were born at less than 30 weeks. So those are our preemies. We had a large number of research publications that came out of that study, and they are listed here. They go from the big study outcomes and then also more specific things, such as how the young child baby's bladder was functioning, how parents were experiencing things, and for mothers, very importantly, what their outcomes were. Because of the way the surgery is done, there was concern that it would impact future pregnancies and change risks around their obstetrical needs in terms of what they might need in future pregnancies. And so this is a list that we have of the original Moms Trial publications, and they're all available online. We were very lucky, though, to also be able to get funding for Moms 2. And this was also funded by NIH. And it was also the 3 centers that were the clinical sites, as well as George Washington University as the Data Coordinating and Safety Center. So the team stayed together, you guys, which was awesome. And this happened between June of 2011 and April of 2017, where we brought those kids who now were 5 years to 10 years old back to the clinical sites for a whole bunch of different analyses, which was really great. And I tell you, it's remarkable that there was the ability to do this follow-up study and that all of these sites were able to engage and do so. So we already answered the question in the MOMS trial, the original one, about hydrocephalus and the need for shunting and the reduction of hindbrain herniation. Those big things that were really important in terms of what we would see shortly after a baby was born. And MOMS 2, or the follow-up, really wanted to look at how the kid was doing. So that was looking at the key findings, which were all about adaptive behavior. So we thought that there would be a difference, potentially, that was our hypothesis, in adaptive functioning as measured by the Vineland. Some of you may have had heard of that. Your child might have had that test done by a neuropsychologist. And it really captures 3 domains of adaptive functioning, which are around communication, daily living skills, socialization. And this Vineland can be administered to people like of all ages. So it's really good tool to kind of look at adaptive behavior. And the hypothesis was that children who had fetal surgery would have better adaptive behavior than children in the postnatal standard repair group. We made that hypothesis before we had actually seen any of the outcome information from the MOMS trial, because we needed to get that study started as quickly as we could after the MOMS trial stopped. And so that's what we thought might happen, but it turns out we were wrong. That's not what happened. There was no significant difference in the prenatal fetal repair group compared to the standard postnatal repair group in overall adaptive behavior. There also wasn't very big difference in the neurocognitive or the thinking skills. There were just a few differences where the children in the prenatal group performed better than the children in the postnatal group. One area that I think is unsurprising to many of us is though that the children in the prenatal group who had less hindbrain herniation, meaning their Chiari malformation was less, performed better on a fine motor scale called the pegboard test. But really not differences in cognitive function or thinking function. But the children in the prenatal group had better mobility and were more independent in their functioning. Their families also reported lower family impact and also reported that their children had higher quality of life. Children who had fetal repair, prenatal surgery, they had fewer shunt placements. They had fewer revisions, obviously, of shunts because they had fewer shunts placed. And in addition, they overall had fewer surgeries. And so that may be why families were reporting higher quality of life and lower family impact. There were a bunch of research that got published out of the MOMS trial. This is the follow-up. And so these are the different studies. And I think what's really important here is that we were looking at all sorts of things, not just the adaptive behavior, but school age functional outcomes that are important and neurologic outcomes. There was radiology studies and looking at the various ways the brains were formed that were different between children who had been randomized to the fetal surgery group and children who had been randomized to the regular afterbirth surgery. So I am super excited to give you some insight about what we are doing in MOMS 3, because this is where the longitudinal long-term data is coming from. And very importantly, the comparison between these two groups that back in 2003 were randomized to either having surgery before birth or surgery after birth. So this is a very comprehensive study, and it is for all of the children, some of who are now young adults, who were enrolled in the original MOMS trial. So eligibility, anyone, whether they had surgery before birth or after birth, who were part of the MOMS trial can be a part of MOMS 3. It's happening at the Children's Hospital of Philadelphia, which was one of the clinical sites, and we are and have been actively recruiting and will be doing so basically until the end of this year. So what this is about is looking at young people. They're teenagers, young adults. So the ages are pretty broad because of how long the study took. The youngest kids were 15 and the oldest young adults will be 24 at the end of our study. And we are so excited to be bringing them in for this follow-up because my goodness, first of all, these young people, we've known about what's been going on with them since before they were born. We have imaging studies, analysis of what things were like before they were born, and how lucky we are to be able to get information about what they are like now as they are merging into adulthood and becoming their full selves as adults. It felt almost essential, like we needed to do the study. And I feel that very deeply in my soul, that we need to know what happens long term. We need to know that because people are still deciding and having pregnancies where they're being considering fetal surgery or regular afterbirth surgery. And we want to know if the benefits that we saw early in life persist in the fetal repair group later in life. I mean, they're only teenagers, they're not that old. But perhaps there's a MOMS 4 after this where we catch them in adulthood. We think it's important to give back this information for all the participants of the study, give to the Spina Bifida community at large, and also for our medical community so that they can know the information that can help guide them in discussions with patients and families. So we are exceptionally excited about it and exceptionally honored to have a home at CHOP that can make this all happen. So basically, what happens long term, 20-ish years later? So our primary thing that we are looking at is the FIM. So the FIM is a study of functional independence. And I'll go over that a little bit, but basically it shows us what people can do in terms of being independent with their motor skills, with their self-care skills, with their communication and cognition skills. And the hypothesis, the idea that we have, the research question, is that we think that children, now the teenagers and young adults, in the fetal repair group, even 15 to 20 some years later, will have improved functional independence compared to the children now, teenagers and young adults, who had the standard postnatal repair. We, of course, also want to look at their neurocognition, quality of life, what's been happening from an orthopedics perspective, how their bladders are functioning, and if they're able to control them, how their bowel is functioning, how they're doing overall in their quality of life. And a really exciting new area is the psychosocial functioning area to me, which feels really important because the job of a teenager is really to assert themselves and become autonomous beings that can take care of themselves and make decisions, hopefully good ones, but we know teenagers, not all the time, good ones. And so we really wanted to see how they were doing in that regard as well. And that is why we needed all of these interdisciplinary experts to come together for this study. And I showed you the pictures of all those amazing people, and we are so lucky to have them involved. And this is truly an interdisciplinary collaboration. And I love learning from the collaborators who are from disciplines besides my own. You heard I'm a pediatric rehabilitation medicine doctor. I think about functioning all the time, but I'm not an expert in urology or neurosurgery or any of these other areas. So we come together collectively to do the work and develop the study, and we'll then be analyzing and reporting that out together as well. So I promised you that we would take a minute to talk about the functional independence measure because it's the main thing that we are looking for. So it has subsections, and those subsections are looking at self-care, sphincter control, like for bowel in your bladder, being able to transfer from one surface to another, locomotion, which basically means like walking and doing stairs, communication, which hopefully I'm communicating something right now, and social cognition. The scale is there's 18 different measures. Is each one of those measures are ranked from 1 to 7. And 1 means that you need total assistance to do that thing. Basically, when you're a teeny tiny baby, you can't do very much on your own, right? You need total assistance for, having a bath, on all of those things. And for most people, the people who do not have disabilities, they score a 7, which means they're totally independent to complete the task. And many people with disabilities will also be totally independent to complete the task. So your minimum score is 18, your maximum score is 126. And we think that the now youth who are fetally repaired way back when, about 20 years ago, will have higher scores compared to those individuals in the study who had postnatal repair. And my goodness, this is a busy visit when you come to CHOP. So it's 2 days, and there is a whole lot going on. There's a physical functioning examination. We do measurements like height and weight. We check your blood pressure. We get some labs. You get neuropsychological testing. You do a whole bunch of paperwork and fill out surveys. There's also a really important, the BUDS, which is a video urodynamic study of how the bladder is working. We also do a DEXA scan, which measures your bone density, and get x-rays to look at things like scoliosis. And we also, as part of our study, are getting records from the outside as well. So previous medical record review of the MRIs or surgery reports. And we also want to know about pregnancies. So, we're now in Moms 3. So obviously we care about the moms who were involved in Moms 1, but now these young women may become moms themselves, the young women in the study. So that's also of interest. And then their individualized education plan, we're doing a review of that to see what sort of services individuals were getting when they were in high school. So I just want to take us a moment to kind of think big picture about how this is all coming together. So you may be familiar with the International Classification of Functioning Disability and Health. This was released by the World Health Organization over 20 years ago, and it basically understands a relationship between our health conditions and our environmental factors and personal factors that lead to impairments at the level of our body, so our body parts. And that can be things like how your body parts move in space, or how they might be unable or have too much range of motion, or how someone might be paralyzed from nerve injury. Also, things like are they tall or short as compared to expected for their age? And are there things like changes to how the foot looks due to the neurologic condition? So those are some things that we're looking at. And I will say, how our bodies function are pretty important. But what people really care about is what they're able to do. So those are your activities. Activities like, walking, or I guess this person is doing some yoga, taking the stairs, doing all sorts of things are the activities that we do in our lives. You've heard the term activities of daily living, like those are examples of things that we do. And when I talk to kids in my clinic, they're not super talking about how just their body parts, they're talking about the things that they want to be able to do. And even more importantly, they want to talk about being able to do things like with their friends and participate in school. And that is why there's a whole bunch of questions for the teenagers that really get about what they're doing in their lives. These are person or patient-centered measures that really monitor or help us identify the things going on for individuals who are involved in the study, and we're able to compare before and after. So as I talked about before, we really want to understand how the bowel is doing and how the bladder is doing. Almost all individuals with spina bifida have neurogenic bowel and neurogenic bladder, and we hypothesize or think that the children after fetal or prenatal surgery will have better bowel and bladder function and management than the children that had regular postnatal surgery. So there's a lot of studies, that urodynamics that I talked about, but also some symptom scores and some labs and looking at the health of the kidney system. I mean, you can't really go to the hospital or to a spina bifida clinic without getting some kind of x-ray, I think. Feels like most kids are getting something. And we're doing x-rays that really look at how, from an orthopedic perspective, the spine and the pelvis, and then looking for leg length differences, and then also looking for how much bone density there is. And for individuals who do less weight bearing on their legs, we expect their bone density to be less. And so we expect that in the postnatal group, their bone density here will be lower than the prenatal group. Just like in moms too, we're doing a whole bunch of studies that assess their individuals' thinking skills. So I told you about the one test that was very much different between the pre and postnatal group way back when they were in school age. We're going to test that again. But we're also going to test just their general cognition and their executive functioning. And then we're also going to ask them, things like, how are they doing? And things that they will report and their parents will report on their behalf as well. So there are a lot of questionnaires that we have. And it seems like a lot to ask. And it is, and we're very grateful that people will participate in answering all of these. But these are things that are important to young people with spina bifida, right? The things that their social relationships, interaction with peers. This is what teenagerhood is all about, right? So we wanted to capture this information. We also wanted to know things about, like, are they ready to be able to take care of their own health needs when they launch into adulthood? So are they ready for transition? How much do they know about spina bifida? Are they having trouble with sleeping? Do they have sleep disordered breathing? And all sorts of different things to really give us a more complete picture of what is going on in their lives now that they're young adults and teenagers. We also look at pain, as a lot of individuals with spina bifida have chronic pain. We look at quality of life. Some of the other things that we've looked at are just carry over exactly from the previous mom studies. And this QALYS, which many of you might be familiar with, is a relatively new measure for quality of life, but we're still doing the one that was in the original as well. So I am going to be handing the slide deck over to the most wonderful Katie Schmidt to take over about what's going on in remote visits.
Thank you very much, Dr. Haltrow. Thank you for that wonderful overview of MOMS, MOMS2, and the specific details about the current MOMS3 study. Thank you very much, Judy, for the introduction at the beginning of the presentation. I'm going to continue here and share with you some more details about MOMS3 and some of the incidental findings found so far and clinical concerns that have been addressed during patients' MOMS3 visits. Ideally, patients and families would be willing to travel to Philadelphia CHOP to have a 2-day on-site research evaluation. However, we certainly understand that life is very busy, and especially for adolescents and young adults, it may be hard to travel to Philadelphia, given school, work, vacations, and other responsibilities. We also understand that it may not be easier for a family to travel given the needs of the person with spina bifida. So we also have a remote option, and you can still participate. The remote visit will be done through a video conference call. The remote visit will only be able to collect limited data, but will still be so valuable. We will be able to collect the primary outcome, the FIM, and some parts of the physical functioning testing. We will send the family all the questionnaires to be completed online. A remote visit will still involve a medical record review and an IEP review, as well for all patients that are seen in person. The study team has noted concerning findings during several patients' research visits and has been able to alert the families of this concern so that the patient can get the care that they need to address it. The findings have varied, with urologic concerns being the most common. Listed here are the urologic concerns noted that were communicated to the patients and families in real time, and then also communicated to their local urologist when appropriate. Patients have also had concerning VUDs, resulting in concern for symptomatic cord tethering, which prompted neurosurgical involvement. Patients also were noted to have high creatinine and cystatin C levels. The next slide is a continuation of concerning findings that were found during some MOMS3 visits. Orthopedic concerns such as mild scoliosis, loose screws after spinal fusion surgery, and incomplete osseous healing after an osteotomy were all noted. We also noted some patients screened positive for suicide ideation on screening for depression severity. All these patients were evaluated in real time by psychology or social work, and none of these patients were noted to have active safety concerns. The study team ensured that the patients and families felt well supported and had resources available to them. Next slide, please. Perfect, thank you. As patients and families learned about MOMS3 and traveled to Philadelphia to be seen at CHOP, several families asked to be seen for clinical evaluations or asked for a second opinion. One patient's mother shared that she worried that her son was not catheterizing appropriately and asked for a visit with urology to reinforce teaching. An 18-year-old female had an intermittent draining wound on her back and was seen by neurosurgery, and then she subsequently had a wound revision with neurosurgery and plastic surgery. An 18-year-old male was experiencing more urologic symptoms and an unstable gait concerning for a symptomatic tethered cord. He subsequently went on to have a complex tethered cord release with neurosurgery. A 17-year-old female asked for an assessment of a heel wound. She was seen in our wound ostomy clinic for wound management. This same patient's parents also requested a speech evaluation for her stutter and clinical interpretation of her MOMS3 neuropsychological testing. As I shared examples here, patients who have been seen for MOMS3 have also brought their clinical concerns when they visited us, and we were able to get them seen by various specialists as needed. There are benefits to families from taking part in this study. This study will establish a standard for long-term follow-up and care for people with spina bifida. The testing done in this study can be used to guide our clinical care. Some of the testing may not be available at other institutions. The results of the testing will be shared with families who participate. And the knowledge gained from this research will help the medical field to learn more about treating people with spina bifida and will help in the treatment of future patients. Following the MOMS3 research visit, next slide, please. All families receive a comprehensive result packet summarizing the pertinent clinical findings that can be shared with their home clinicians. Many of the studies done for MOMS3 are part of standard routine care for people with spina bifida. Often, if a test is done for MOMS3, this allows that test to not have to be done clinically for the patient in the near future. The results packet contains a letter summarizing the neuropsychological testing, all radiologic images that have been done, the VUDs tracing and data, labs, and select questionnaires that are clinically relevant. Next slide, please. All study visit procedures and travel expenses are paid for by internal funding here at CHOP. The study covers flights for the patient and one parent or support person. If you choose to drive, mileage will be reimbursed at the allowable government rate. Lodging will be paid for by the study team for 3 nights. We will also reimburse a per diem rate of $118.50 per day for 4 days to cover meals for 2 travel days and 2 research visit days. At the end of all study procedures, the adolescent or young adult will be given a $150 as a thank you for your time, effort, and inconvenience. MOMS3 is already highlighting the importance of longitudinal multidisciplinary follow-up. Continued long-term follow-up is imperative for all patients with spina bifida as people age into adolescent and young adult years. We've also noted that transitioning to adult clinicians and clinics can cause lapses in care for these patients, worsening outcomes. The findings from MOMS3 will allow us to better counsel parents expecting a baby with spina bifida as well. I will now transition and hand it over to Amber, who will talk about specifics surrounding enrollment in the MOMS3 study. Thank you.
Thanks, Katie, and thanks so much, Amy, for getting us started and giving such a great background of Moms 1 and 2 to really set the stage for Moms 3 and where we are now. So this slide is just kind of giving you a sense of where we are today. We're in our 4th and final year of the Moms 3 study, and our target enrollment is 110 subjects, and that includes index subjects, which is the child, and then also the parent. We are working our way toward that goal. We have done a pretty good job of staying up to date with all of our targets. As you see here, in that first year, we actually had a bit of a delay in starting. So we were targeted to start in February of 2023, but actually didn't start until about midway through that year. But we are catching up with our enrollment goals so far. And that's why we're here today. We need your help to sort of get us to that final number. Next slide, please, Amy. As of today, we have 102 people enrolled, and we've completed 78 visits, which is amazing. We are like inching closer and closer to that goal every single day. We have 6 that are scheduled to come in, so we are slated to be at 84 very quickly, which is great. So just a couple away from really getting there. Next slide, Amy. And this is just a breakdown really quickly to see kind of where people fall in closure type of who we've seen so far in Moms 3 and who we've enrolled. And what this is showing is just kind of the breakdown that you see. We really have seen about half of our population, really it's almost close to 50-50 that we've seen individuals who had postnatal surgery and fetal surgery, which we're really excited about because that really allows us to compare across these two groups without it being too skewed in one direction or the other. And so we just wanted to show that breakdown here. Next slide, Amy. Because this third study is being done at CHOP only, we are a little bit skewed towards most of our population to date anyway has been from the CHOP pool of individuals who were in the initial Moms 1 and 2 trial. So if you look at the breakdown here, you'll see that from Moms 1 and 2, about 40% of those individuals were initially seen at CHOP for those 2 studies. And we're seeing about 60% of our pool for Moms 3 have come from that initial CHOP enrollment. We are seeing about 30% from UCSF, which was similar to what we saw in Moms and Moms 2. And really, we're trying to close that gap with our Vanderbilt patients. So that's where we're kind of missing some people, and we're really trying to get those individuals in and on site at CHOP. So this is just to give you a little bit of a quick overview to see kind of where things are headed as far as the distribution of participants across each of the 3 initial sites. Next slide, Amy. So I want to talk really quickly about what the next steps look like for screening and enrollment in this study. So Amy and Katie both talked a lot about the really busy 2-day research visit that you have to do on site. And I would just like to touch on how we get you there. So what we initially do with individuals who are interested in the study is that they reach out to us, and then we have a phone call to assess eligibility. Typically, eligibility criteria is just that you were involved in the first Moms trial. That's really it. There's not a whole lot else included there. And then we do a review of any relevant medical history, and we talk about scheduling. The screening process does include verbal consent for screening and enrollment. And I like to just bring that up because since we have an age range of individuals who are between 15 and 24, we have some that are under the age of 18 and some that are over the age of 18. And it's really important that when we do the screening that for any individual that is over the age of 18 and able to consent for themselves, we do need to have the conversation with them and not just their parent when we're enrolling them in the study initially. Typically during this phone call, we gather contact information, talk about your travel preferences, and then we sort of do a brief urologic history just to get a sense of maybe when your last VUDS was, have you had a bladder augment, to try to inform how we schedule you for the research study visit. So most of what Amy and Katie talked about is done for everyone during the 2-day visit. But if someone has had a bladder augment, we typically would not do a VUDS, or if they've had a VUDS or other procedures within the last year, we sometimes can get the results from those and then forego some of those study procedures, depending on the information that we gather during this screening call. Next slide, Amy. So I am going to go ahead and hand it over to Colleen, who very graciously has joined us today to share her perspective a little bit on her experience participating in the Moms 3 study. So I'm going to go ahead and kick it over to you, Colleen, whenever you're ready.
Okay, I'm ready. I'm Colleen Payne. I live in Louisville, Kentucky, and I have a 19-year-old son named Nate. We did fetal surgery at Vanderbilt 20 years ago, back in March. And Nate was going to join me, but he's not because he's 19, and you know how that is. But when I heard about the Moms 3, I was really eager to participate in it. I'm really proud of our participation in the Moms trials and our contributions to science. And it was such a difficult experience, from the diagnosis to the surgery to the recovery, prematurity, NICU time. The whole experience was so hard. There's no way we're not going to go through with the follow-up studies to help demonstrate the results of fetal surgery. So we saw benefits, and I'm glad we did it, but I want to make sure that that experience counts for as much as possible. So that's another reason we wanted to participate in Moms 3. Also, Nate and I like to make the most of our, I call it Spina Bifida tourism. Whether we travel for medical care or for conferences, we're going to see the sights. We're going to have a good time while we're going. And so I asked Nate if he wanted to go to CHOP. He asked what he would have to do at the hospital. I showed him like the schedule, the blood work and x-rays and assessments. And his only concern was if he had to do urodynamics, because he's not a fan, but he had done it within the past year, so he didn't have to have it done. And he was like, okay, no big deal. Let's go. It's totally worth that for a trip. That's easy. That's another Tuesday. So we had a great visit to CHOP. We had never been before to CHOP or to Philadelphia. So we went in February 2024. And it was a long couple of days, packed full of stuff, but we had breaks and lunch, and there were lots of surveys. But everybody was really friendly and welcoming, and they made it a fun time, especially the physical therapy assessment with Janet Jackson Cody. Nate had a really good time spending time with her. And even at the end of the day, Nate got a flat tire on his wheelchair, and they fixed it for him. So they're just there for the patient and parent. It was really easy to work with CHOP on the travel arrangements. They put us in a hotel that was really nice and close to the hospital, within walking distance. And they made sure we had time to explore Philadelphia, since we had never been before. So we went to the Philadelphia Museum of Art and Love Park, saw the Liberty Bell, ate some cheesesteaks, like all the essentials. So I appreciate all these follow-up studies. I'm grateful for the Moms trials and how they have impacted my and Nate's lives. And I love knowing that our experience helps current expectant parents make treatment decisions. That's all.
Thank you so much for sharing that story. It really brings it home what it's actually like to be a part of the Moms trial from the very beginning. And I think that we can all express our gratitude for all of the families, but especially I appreciate that you're here to share why you continue to be involved, because everyone who enrolls in research is participating in something bigger than themselves, but their own lives are what they have to consider when they make those commitments. And I'm incredibly grateful for all of the families who made this commitment at a time that was pretty stressful, when you're pregnant and find out that your baby has spina bifida and there's choices you need to make about surgery. So I'm very much appreciate your story, and then express my gratitude and our gratitude to all of the folks enrolled. Katie, can I give this back to you for our last slide, or Amber?
Yes, Amber will finish up here.
Okay, yeah. I do want to thank Colleen and just echo everything that Amy said. I think you did such a great job of really highlighting exactly what a visit feels like. And I'm glad to hear that despite some of the more challenging procedures and more uncomfortable procedures, you all still had a good time and you were able to make the best of it. So how to enroll? These are the ways to get in touch with us. You can email us at this email here. And if you scan this QR code, it actually takes you directly to our email. So very easy to do if that's something that you're interested in. You can also call at 1-800-IN-UTERO, or you can text us. If you text this, you will get directly to me and I will answer you nearly immediately. I don't want to guarantee that because we all have things happen in life, but I do always have the phone on me, and I'm always happy to answer any questions that anyone has, even if you just want to have an initial conversation, and follow up on a few things that maybe we didn't cover here today or that you didn't want to talk about today. You can always send us an email, send us a text message, give us a call, and we're happy to talk further. And I
Well,
think we
this,
turn it over for questions.
yeah, is the end of the presentation. We're so incredibly grateful to the Spina Bifida Association for allowing us this time, and we look forward to the dialogue we're about to have with you all with the questions that you have.
And we do have a few questions. The first one came in through the Q&A, and the question was, since every child with spina bifida is different, how are you normalizing this data and able to actually compare the two different groups? Are you comparing the patients that have the same spinal level of impairment? Please explain how this analysis was done.
Well, I think that's a question for me, and I will take it. So part of the reason we do randomization, this happened way back when moms and their fetuses were enrolled in the study, the original moms, is it's basically a coin flip which group you're going to go in. And the study groups are big enough that basically what evens out is the kind of level of the lesion that you have. I want to go back into a little bit more data about this, though, because we did look at this exact issue. So, if you're a neurosurgeon or a radiologist, for you, the level of the lesion is the anatomic, bony area where it starts. And we defined that in moms on the 1-year-old x-ray that they got. So all the kids were measured on their 1-year-old x-ray for the level anatomically. But one of the really interesting things, if you're a rehab doctor, you might think about, or a neurologist, think about the motor level of the lesion, what the motor functioning is. And sometimes the motor function can be better than the anatomic level, and sometimes it can be worse. So we actually looked at this exact question for the fetal repair compared to the postnatal repair to see if their level of their lesion anatomically was different than what they were found to have in terms of the motor level of their lesion. So just very broadly, you might have heard of like a lesion level of L3. And when we say that from an anatomic level, we mean the lumbar vertebrae, number 3. And when we mean that from a motor level way, we're really talking about, does that individual have quadriceps or the quad muscles in their thighs that work? And so when I talk about a motor level of level 3, L3, I'm talking about they have muscle strength in their quadriceps, they have hip muscle strength as well. What we found in the mom study is that children who were in the prenatal group had better motor function than what would have been anticipated just based on their anatomic level. So the kids who were in the prenatal group, if they had an L3 anatomic level, sometimes had L4 functional or motor level, or L5 functional or motor level. So their functioning was better than we would have predicted based on their anatomic or bony level. And that was more likely to happen if you were in the prenatal group. So the prenatal group had some nerve protection to the nerves that go to their legs and control those muscles. And that gives them better motor function. And so that means when we do their motor level assessment, it's often better than we anticipated compared to what we would expect from their anatomic or their bony level. But the randomization is the best way that we make sure the two groups are similar. Like similar in age, and that's similar in gender and all of those things. They did look at this in the original mom study to look at the differences between the two groups. But we were very excited to find that the motor levels were often improved more in the prenatal group than in the postnatal group.
Great. Thank you. All right, good. We have a couple more questions that were submitted. Is there an estimated publication date for the MOMS 3 results?
I can tackle that one. We're shooting for the first half of calendar year 2027 would be the plan and the hope.
Awesome.
And
And
if I would just put a plug in, the sooner we get people enrolled and seen, the sooner we have the data so we can actually analyze it. You know what was we just talked about wasn't actually any of the data that compared, the findings from the prenatal and postnatal groups in MOMS 3. We're not looking at that yet because we got to get everyone through the study. So the sooner we get the study done in terms of enrollment and seeing them, the sooner we get to publications. And we are very excited to share and disseminate the information.
very good. Awesome. So, will they be continuing to follow the mom's patients further into adulthood? And the person who submitted this added that their 22-year-old daughter and her are part of the original mom study and do all the follow-up studies. She was born at CHOP and they were the second family in the study. They're very thankful for the opportunity to support research and benefit from the wonderful care at CHOP.
Thank you. That gives me goosebumps when I hear things like that. We so appreciate the continued involvement. Thank you. I I can tackle this, and then Amy, you can add to it. I think we hope to continue to study this group of patients for sure. We've joked around that maybe that would be called grandmoms, but we'll see. We are, as part of enrollment in MOMS 3, we are asking if we can retain your contact information. And most participants have agreed to that. So we will retain information and we'll certainly be in touch with you in the future for future studies.
Yeah, I certainly hope so. And who knows what that might look like. It may not be as intensive a study as we're doing right now, where you come on site for a couple of days. But oh my goodness, the most studied cohort of individuals with spina bifida in the world. And they keep being willing to help us do the research to share with the world. I certainly hope that there is a MOMS 4. I won't be retired yet, I hope.
Very good. Thank you. And so the next question is that my loved one had fetal surgery in Houston where an umbilical cord patch was used with a repair. Are any children with a patch involved in this study as well?
So in this study, it's only the kids that were in the original mom study, and they were not doing patch closures in the original mom study. But what this person is alluding and sharing with us is that there's been a lot of advances in this space, and it basically all is built off of the MOMS trial. So the MOMS trial was so fundamental to the study and knowledge about fetal surgery that all the other work that has come after has really built upon. And it's really amazing to see all these really smart investigators choosing to study spina bifida, which we, Judy and I know it's been something we've been advocating for decades, is really good study of spina bifida, because we all want people to live full, happy, and healthy lives. And without the research to show how to do that, we aren't able to fully help in the ways that we want to, whether that's as researchers or clinicians, or even just those of us who are just really invested in helping people live their full lives and be as healthy as possible.
Just to add to that, in the original MOMS trial, there were some patches used to close the skin if the surgeons weren't able to get the skin completely closed, but they didn't involve stem cells like are being used today.
Very good. Thank you. Well, we have some additional logistical questions that maybe you can help with, or that for sure you can help with. Who will arrange all my travel and how will I get that information?
I'll take that because it'll be me. Yeah, so like I said, part of that initial screening call is really to talk about your travel, your preferences, what are the dates that you want to travel. We typically will cover travel, whether that's flights or if you decide to drive, we cover mileage for the subject and one support person, which usually is a parent. We have had participants come with other support people, friends, boyfriends, girlfriends, that sort of a thing. So we typically will cover flights and travel for 2 individuals. And then if families want to bring additional people, that would be at their own expense. And we also book the hotel for you, and we cover 3 nights in a hotel. And all of that information gets sent to you well ahead of time. I do my best to work with families to kind of make sure that we're giving them flights that make sense for them. I know with Colleen, when she came in, we worked really closely with her to say, do you want to sightsee in Philadelphia? Let's try to get you in on an early flight so you've got like a whole day ahead of you before you need to come in for the study. And then we'll send you out on a later flight so you have time to sort of decompress and maybe do a few additional things before you leave. So we keep that conversation ongoing, and I take care of all of that and share all the information with you when it's booked.
And what if my child has recently had some of the procedures that are included in the study done for their usual care?
Sure. So that is part of the conversation as well. When we do that initial screening call, we like to find out, typically we say if they've had certain things done within the last year, there is the possibility that we can use them for the study. We do like to go in and review those procedures just to see what was captured, what were the results. Maybe there's something missing from what their usual provider collected that we might want to see for the study. I would say most of the time we are able to take those if they were done in the last year, but we do review them first just to make a determination about that. Something that's really common is sometimes people will have had a video urodynamic study in the last year. And so we do our best to try and make sure that that's something they don't need to repeat. It's not a comfortable procedure. We know that it's definitely not everyone's favorite thing to do, as Colleen shared. So we do our best to try and decrease the number of times that you're needing to get procedures done. So if they've had it done recently, we'll review it and have a discussion about whether we can use that. And then they just skip those procedures when they come in for their study visit.
Well, thank you very much. I think that that's about it for all the questions.
So if anyone is out there who has thinking they might want to enroll and want to learn more, this is the way to do it. And as Amber said, that text basically goes to her. I wonder if you text her right now, what would happen?
Well, my phone's in my bag, so but I would probably answer within the next 20 minutes. It's not right at my fingertips.
If you know someone who's interested and you can't find this information, you can reach out to the Spina Bifida Association. Juanita, we know this stuff, and we are really lucky to have these 3 scientists sharing with y'all what is going on in this really, really important study. So thank you all for what you are doing and will do. Waiting for that paper in the first half of 27, which is quite a goal, right? So come on,
Very
y'all.
cool.
Let's get the enrollment up a little bit more.
And I hope that we can be invited back eventually to share what
Yes.
all of the results taught us.
Yes. Thank you. Thank you.
Thank you all very much. Thank
Yeah.
you, Judy and Juanita, for hosting us in the Spina Bifida Association. Thank you. And thank you all. Thank you, Colleen, for sharing your story.
And we
I
appreciate
look forward
you
to hearing from some of you, hopefully. I look forward to being in touch.
Good night, everyone.